trained in the UK as a non-medical specialist in public health, but I trained in the National Health Service in the UK, where we have the unusual situation of a training route, which is fully funded training route through the National Health Service, open to medics and non-medics in the UK, and I was delighted to be one of the first non-medics allowed on that program in about 2004 or so, and learned a great deal on it, and was delighted to be working over here in Australia for a bit as well, and then moved over here because it's way easier to get exciting outcomes in Australia, frankly, than it is in the UK. And I'm more than happy to chat about why that might be later on. I'm also going to be talking not to the camera. I'm going to be talking to Jonathan Mallow. Jonathan, do you want to come over and say hello?
Hi, everyone. I'm a second-year trainee that's here at Vic Health, training under Bruce's guidance and genius at the moment. I'll be behind the camera.
Yeah, Jonathan doesn't get enough of my pills of wisdom. He needs to come to one of these sessions. Hardly. Now, unfortunately for Jonathan, I do talk a great deal. I'll be trying to open the session up today. So if it's okay with people, as I understand it, people can speak and I will hear you on this. So I'd like to sense of, can hear the thing going times. So there must be a few people online. Maybe if we just do a very quick round robin to get an idea of how many people online. I would like to open up for questions later on. If there's anybody there, can you say your name? Interesting. No responses?
Guys, just remember you are not on mute, so if you just turn your microphone off.
Okay. Okay, let me just check. No, I'm definitely not on mute.
No, Bruce, you're fine. It's just everybody else has to remember, if you want to talk, just make sure your microphones aren't red.
Hi, Brittany, is there any sense of how many people might be online or not?
We have 11 online at the moment. Trent doesn't have a camera or a microphone, and Dr. Chang does also not have a camera and a microphone, and that's it.
No problem. So just as a bit of advance warning, I'll give Jonathan some advance warning too. It'll probably be about half an hour or so for me to run through the slides, and I was planning on just opening up the rest of the session as a bit of a question and answer. And so if people want to start thinking about those questions on their way through, Jonathan as well, and if in doubt, if people can't relay those questions because of audio-visual things or whichever else, Jonathan will have a couple of questions and we'll just have a bit of a dialogue about some of the critical issues. So what I thought would be useful for folk today is that really this is going to be a very high-level snapshot on health promotion frameworks and issues very broadly as relevant to, I anticipate oral exams, towards the end of your training. So it's just going to be a chance to kind of step back out of stuff that I'm sure most people will have covered in their MPHs and look at some of those principles underpinning health promotion and the major kind of frameworks you might want to think about potentially using as you get towards your exams. Okay, next slide. So just by way of overview then, we're going to start off with some definitions, move on into some ethical considerations in public. And there are ethical considerations which are broadly relevant to public health as well as specifically to health promotion. It just, in terms of helping you frame your answers, there are some issues, particularly in health promotion, around nanny statism and kind of this idea that as health promoters or as public health people, that somehow we're the cold dead hand of the state, and that we're wanting to just be the fun police and stop people having a good and happy life, and nothing could be further from the truth. And there's some of these ethical frameworks which can help us get the balance right, particularly in a media context or in a public framing, to make sure you don't get seen as the thought police. We're going to go on to talk a little bit about some of the determinants of health, and obviously they're relevant to health promotion. I'm going to dwell very quickly on Jeffrey Rose's concepts of population and high-risk approaches as applied to population health improvement, because they are quite different strategies. And then I'm going to go on to look at the principal things that could come up in your exam, I imagine, or some of the key risk factors certainly that could come up in the exam, particularly tobacco, obesity, and alcohol, before then opening up to general questions. So to start off with then, a couple of definitions, stuff you'll be familiar with, but it's worth revisiting. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. Now, a WHO definition from 1946 stands true now as it did then. The point with that is that most of the time in public health, let alone in certainly in clinical health care settings, we tend to focus, of course, on the absence of health, illness, and indeed in lay representations of health and illness, something I myself researched quite a bit back in the UK, did my PhD in this kind of area. Commonly when you talk about health, what people actually mean is illness. So they mean illness, disability, and death. It's very rare that we talk about health as a positive sense of well-being and empowerment. And the key issue here goes on to the next one, which is from the Ottawa Charter in 1986, which is the definition that health promotion is the process of enabling people to increase control over and improve their health. So that can be narrowly defined, and it often is, by the rather oxymoronic, in my opinion, term of preventive health or preventative health. My answer to that would be no one wants to prevent health. You want to prevent illness, disability, and death. And we can do something about that. We can prevent particular causes of death, or we can delay death or disability, but we can't stop death. We're still going to die of something. Every death prevented by cardiovascular disease is instead a death, of course, by cancer or dementia or some other cause, albeit at a later point, hopefully at a later point, and hopefully with better quality of life along the way. So health promotion is definitely not just about preventing disease and death, although that is a common rubric which is used to kind of explain its relevance. It's also about quality of life. And this will bring me into some of the ethical issues that we need to get our balance right, particularly in health promotion, to kind of get our calibration right in the interventions that we're designing. So the Nuffield Council of Bioethics in the UK developed a lovely framework back in the sort of, I don't know, about 2008 or so, in which they looked at public health very broadly, and it's definitely worth looking at the Nuffield Bioethics Public Health Framework. It does relate to a lot of different areas: sexual health, infectious diseases, a whole bunch of different things. I'm going to talk about it with relevance to health promotion. But what they put forward is a stewardship model of public health, where basically we say, okay, the legitimate goals of a public health effort is to promote the health particularly of children and vulnerable people, because by definition, they're vulnerable. They're not entirely, their autonomy has been impinged by their circumstances. So we're in the business of protecting them or promoting the health of them. We're trying to help promote, overcome addictions and other unhealthy behaviors, which clearly are very relevant to health promotion. What this gets along to is the concept of autonomy, and the fact that we do, in some instances, choose our behavior, but a lot of the time we don't. You know, we operate, broadly speaking, fairly on a habitual basis. And if we did originally think about that behavior, certainly most of the time we don't think about it. And we can, you can think about all sorts of aspects of your day-to-day life. What did you do this morning? What did you do last Wednesday afternoon? You can probably take a rough punt at it. What choices were you making at that point? Not sure why, because mostly we're flying on autopilot. You know, we're pre-programmed by our environment and by our brains, our neurology, to make snap decisions very efficiently. And as a result, we're in the business of trying to help people overcome some of those unhealthy behaviors which have reinforced themselves over time. The next legitimate goal is ensuring that it's easy for people to lead a healthy life, for example, by providing convenience and opportunities for exercise. This is a very long way of saying making an environment where the healthy choice is the easy choice. And that is a fantastic mantra to roll out pretty much in any answer. So it's about valuing the fact that people do make choices, but it is about trying to create environments where the healthy choice is the easy choice as opposed to the hard choice. While we're in that game of preventing harm to vulnerable people, helping people overcome addictions and unhealthy behaviors, and trying to create the conditions for a healthy life, we need to recognize that that does potentially adversely impact on individuals' autonomy. Therefore, we shouldn't attempt to coerce adults to lead healthy lives. The definition of coerce here, of course, is that's where the art lies, and if you're interested in that, I'd go back to the Nuffield Biocouncil and their fantastic ethical brains that have unpacked that in quite some detail. The point here is it's a bit of a slippery slope argument. You know, it's a bit of a sliding scale of what counts as coercing and what counts as encouraging. We need to minimize interventions that are introduced without individual consent for those affected or without a just mandate, such as through democratic decision making. And this really goes to the core of public health. We're not, in clinical practice, one is getting consent from an individual. We're asking that person, in your situation, what I recommend is this treatment pathway or this set of tests or whatever it would be, and that individual makes a decision for themselves. And if that individual isn't capable, we have a whole set of rules and regs for dealing with that ambiguity. In public health or in health promotion, most of the time we're working at a community or population level. That means that we cannot consent individuals in the same way, and therefore we have to be particularly concerned about the mechanisms through which we do get consent for our actions. And it gets to that critical issue of the fact that Hitler famously was a Nazi and an anti-smoker. Is a Nazi, an anti-smoker, and a vegetarian. So he's a vegetarian and an anti-smoker. So actually he had a very, in inverted commas, healthy lifestyle. Now it's interesting, in Germany, tobacco control is far less progressed than the rest of Europe and still has that hangover of a concern, with Nazism and the past of Germany, which is still a very current issue for many people culturally, and it's actually tied up to that fact. So we've got to be very, very careful in all this space, not to just be pulling solutions off the shelf and handing them out because it's good for health outcomes and riding roughshod over individual autonomy or over democratic decision making. The final thing is that we need to seek to minimize interventions that are perceived as unduly intrusive and or in conflict with important personal values. So that's really about saying that there's a lot of flex in public health and in health promotion around acknowledging the fact that we are working at a social level, at a community or population level, and therefore we have to be very, very careful in how we advise, make recommendations and reforms that can impact people without getting their consent. And I'll come back into that when we talk about the prevention paradox and Jeffrey Rose's stuff. Now, the most interesting bit of all coming out of this prevention this concept of the stewardship model is an intervention ladder. And this intervention ladder is about balancing the intrusion or impact of those interventions we're looking at doing and its impact on autonomy. And basically the case we need for change is to be stronger and stronger each step up the ladder. So at the bottom step, we simply do nothing or monitor the current situation. Requires very little justification. The next step is to provide information. For example, campaigns to encourage people to walk more or eat more fruit and vegetables. And many notable public health people are very clear that they think that this is where a large part of the battle should end. Very respected figures such as the early tobacco control folk in the UK at Oxford, including Richard Peto's mentor, Doll and others, really argued that it was about they were providing information rather than just making decisions for people. Just providing that information out there. The next one after that is to enable choice, for example, by building cycle lanes or providing free fruit. The next one up after that is about guiding choices through changing default policies. So rather than the standard side dish being chips when you walk into a hospital, you walk in and what you see is the salads and fresh fruit. And if you want to ask for hot chips, they are available. And that's obviously changing the default bit of the dial. And it can be extremely effective as a strategy for guiding behavior. The next one after that is guiding choices through incentives. For example, giving a tax break on buying a bike for traveling to work. The next one after that is guiding choices through disincentives, so taxing behavior, one of the single most effective strategies that we know in public health, which is core economics. Make it more expensive, people will do less of it, but it does require a stronger justification for why you're incurring that cost there. Restricting choice, so for example, restricting the sizes of sugar-sweetened beverages. Now, anyone who's been following that situation over in New York will know the degree of consternation Mayor Bloomberg's proposals in New York caused. And it's interesting to note that even after, Bloomberg, he's a billionaire, he was running the city of New York. Even after all of his push, it still didn't happen. Hasn't occurred. Right? And there's a lot of interesting discussions you can have about why is that. But fundamentally, there is a lot, and justifiably and understandably, a pushback when you try and restrict individual choice, and we can look at some of the clauses around that. If, by the way, you're not convinced around the guiding choices through disincentives and the harms associated with that, think of the remaining tobacco smokers now, someone perhaps with dual diagnosis, living on a very low income, in a commission flat, older person, been addicted for 40 years to 60 cigarettes a day, who is currently paying approximately 20 per pack of cigarettes, right? That is a very, very real economic impact on poorer people if they don't quit. Now, you can make an argument to say it increases the likelihood of their quitting. Yes, and indeed it does. But of course, not all people will quit. So what do you do with those remaining people who are remaining smokers and who are being taxed through a, frankly, regressive taxation regime? So that's just a kind of an illustration of you can slice it different ways. You know, it can be for the public good, but it can also bring harms along with it. And finally, of course, we've got eliminating choice through isolation of people found for infectious diseases. We don't often do elimination of choice apart from through legislation, and it's very tempting in public health to kind of jump immediately in health promotion. If we could just legislate and eliminate X, Y, and Z, we'd get it sorted. And I think I'll come back to some of that. And it can be a very powerful tool, but it can also not necessarily give all of the royal answers that one would hope that it could. So that's ethics in the background. Why I wanted to go through that is that it's important in your messaging around health promotion that we're in the business of making the healthy choice the easy choice. We respect individual autonomy, but we do want to influence to get the best outcome in the context that there are lots of influences happening out there which often drive unhealthy behaviors. And that's a pretty safe space to be. When you start moving away from that, it can start sounding pretty nanny-statey, or alternatively, it can sound like you're ignoring the things that shape individual behavior. So the Ottawa Charter in 1986 really is the framework I would suggest for any kind of answer to an exam question around health promotion specifically. There's 5 main recommendations for action in there: building healthy public policy through legislation, fiscal measures, taxation, organizational change in all government policies. That's easy. Creating supportive environments through physical and social living and working conditions that are safe and sustainable. Strengthening community action through empowerment and community development. Developing personal skills through provision of information, health education to support the personal and social development of individuals, and reorientating health services to broaden from curative medicine to the prevention of disease. Now, those things in 1986 really still stand true today. And while we've made particular progress in aspects of reorientating health services, it's still important to note they are healthcare services. They're really illness and sickness and disease services rather than health services in the main. So there's still a lot of opportunity in there. Another way of articulating that, and this is from Whitehead and Dahlgren in 1993, is to look at this kind of onion model of health outcomes, at the core of which you've got sex, age, constitutional, fixed biological factors, then you've got individual lifestyle factors, social and community networks, wider conditions of living, and ending up in the socioeconomic, cultural, and environmental conditions. So any health promotion intervention which is going to be sustainable and impactful in the long term usually has a mix across those different layers of influence, usually. Not always, but usually. And as I get into the specific risk factors, I'll illustrate that a few times. Now, Jeffrey Rose, what a genius. Unfortunately, sadly, no longer with us. If you haven't read it, the book you need to read is this book, The Strategies of Preventive Medicine. If you haven't read it, I strongly, strongly recommend it. Yeah, just a cracking book, a cracking read. Summarizes hugely important kind of epidemiological kind of insights, which are relevant not just in health promotion, but right the way across the piece. And a couple of the most important ideas that Jeffrey Rose is credited with promulgating is particularly around high risk and population strategies and the prevention paradox. So when we're talking about high risk, those kind of approaches are targeting a population with a particular risk profile. That kind of an approach has a very high benefit to risk ratio and is well applied in clinical settings. So you're really talking about identifying an individual, for example, at elevated risk of a cardiovascular disease event. You look at their absolute risk, their risk profile, you figure out, okay, clinically this is where you're at, what's your likelihood of an adverse event occurring in the next period, and we should focus some interventions towards that behavior. However, and this is Jeffrey Rose's principal insight, when risk is widely spread, a larger number of cases may occur in the so-called low-risk group. And of course, the cutoffs that we use to determine what is high blood sugar, what is low blood sugar, what's high blood pressure or low blood pressure, are in large parts fairly arbitrary cutoffs. Often we get more cases in the so-called risk than elsewhere. Population level strategies, therefore, are simple, are efficient, and are highly cost-effective. Brittany, I think I'm just getting a little bit of feedback there on my talking. I'm just hear some coming back.
Hang on. Try now?
No. Yeah, I think that's that. Yeah, that's good. Perfect. Thank you. The most cost-effective interventions are often population-level primary prevention interventions at the population level. A really good example of some of those is from the Vic Health-funded ACE prevention study, assessing cost-effectiveness, which identified that a lot of the major DALYs that could be prevented and in the most cost-efficient way prevented are things that operate at a whole population level. For example, tobacco taxes, alcohol taxes, mandatory salt limits in processed foods. These kind of come in as highly, highly, highly efficient ways of doing population health improvement. So it's all about that balance. Before I go on to the specifics of the example, another of the issues here, though, is the prevention paradox, right? So the big disadvantage of the population level approach is to put it in the long and the short. You can click for a lifetime and never benefit. At a population level, we know that one of the most effective ways to reduce road traffic injuries is regular seatbelt use. And that's formed, of course, a major plank of road traffic injury control here in Australia and internationally. And you can see that in the stats. You know, when you get everybody to click, it will drive it down. However, the absolute risk of being injured in a road traffic accident is actually quite low. So most people will be clicking their entire life and will never benefit from that. So you end up actually with a lot of people having to comply to something which statistically is beneficial for the population, but probably isn't going to benefit them individually. And again, that takes us straight back to that original point around the ethics of changing the environment and influencing individual behavior, and how important it is for us to carefully consider that. So I'm now going to give a couple of examples of different frameworks you might want to think about applying to different areas of health promotion. Firstly, tobacco control. The good news in this is there is a WHO-endorsed framework that you can learn for your exams if you're so minded, and roll that one out. It's called the MPower framework. So the first bit is monitor tobacco use and prevention policies. The second is protect people from second-hand tobacco smoke. The third is offer help to quit tobacco use. The fourth is warn about the dangers of tobacco. The fifth is enforce bans on tobacco advertising, enforce bans on tobacco advertising, sponsorship and promotion. And then finally, raise taxes on tobacco, the MPower framework. What that shows there is a really beautiful combination, as I was referring to before, of different levels of intervention. On one hand, you need to be informing individuals and providing services to help them in their quitting behaviors, but you also need to be thinking about the environment in which they're making those choices, be that the environment where they're being advertised to, or that cigarettes are being pushed into. Then you've got to start thinking about that wider environment, also from a secondhand smoke perspective. Here in Victoria, we just announced yesterday, finally, Australia pretty much is going to be clear of smoking in outdoor dining areas. Now, outdoor dining areas, for your information, the secondhand smoking harms of those really are more of an inconvenience than a major public health threat. The more important part of that intervention is the denormalization message that it sends, and the research is very clear. Outdoor and other bans on tobacco smoking are particularly powerful in sending messages to young people prior to their uptake of smoking. So what's interesting is in that halving of smoking rates that Australia has seen in the last sort of 20, 30 years, most of that is actually attributable to a lowered incidence, less young people taking up smoking than it is about quit rates. The reason why is that quitting is phenomenally hard. It's just very hard to quit. So most people, by the time they're fully addicted, will struggle to quit, and obviously half of those will die, usually within about 15 years, earlier than they would have because of smoking-related disease. So that's probably the biggest argument around why you'd be coming so heavy on tobacco, is because it has such a massive impact on the life chances of the individuals who smoke, but also on those individuals who aren't yet smoking. So there's a very strong mandate there ethically, not just to focus on smoking to the individual, but also secondhand smoke, but also denormalization. is actually a very strong, ethically justifiable route. And to put that in context, in Victoria and in Australia more broadly, we had something about 1 in 4 all teenagers was a regular smoker by the time they were sort of 15, 16, 17 years, about 20, 30 years ago. That's now down to 1 in 10. Now, that's a colossal change, and that's really what's driving the reduction in smoking rates. That, and unfortunately, people dying. So the smoking rate in the population is going down. So you're informing individuals, you're providing services to individuals, you're focusing on the immediate environment of individuals, the packaging, the advertising they're being exposed to, the physical environment they're in, and then at a larger level, you're looking to see, what's the tobacco prevalence like, what are the prevention policies in place, you're taxing it, you're taxing tobacco. So you've got a huge amount of multifaceted strategies there. And probably tobacco, certainly in Australia, is one of the biggest success stories of the last 34 years in terms of promotion. There's nowhere else, no other single area that have we made as big an absolute contribution. And I mean, if you think about the cardiovascular disease risk reductions that we've seen over the last 20, 30 years, half of that is attributable to all of the improvements in clinical diagnosis, identification, management, tertiary prevention, The other half, reductions in smoking. So it's phenomenally efficient as a way of improving population health outcomes. Probably the most notable other big one in health promotion in Australia is the TAC campaigns against road trauma, which have radically brought down rates which were very high indeed back in the 1970s. And it's exactly the same mix of regulatory, individual and other infrastructure changes achieving long-term changes. So just to illustrate that further, here are the major events in tobacco control over quite a long period of time. And what you see on this graph, you can peruse this at your leisure, is that when those interventions occur, they really accrue over time to drive down prevalence. And to put that in context of the life of an individual smoker will very rarely, if ever, stop as the result of seeing one advert. Right? It's more the constant drip, drip, drip. And Simon Chapman, the esteemed tobacco control leader, is very good at articulating this in terms of saying, Barry starts smoking behind the bike sheds at the age of 15, becomes a tobacco smoker, isn't too worried about it until he becomes married. Then he starts getting hassled, and he's starting to get these messages in the background. He's seeing stuff on the TV, he's hearing about tobacco and how bad it is, but he's not too worried about it because, he's a young guy in his 20s. He gets hooked up, his wife's concerned about health, he's not so bothered. And it's not really until he has his first child that actually he really starts thinking about, hang on, I want to be around, in 40 years' time for this kid, I'll make a quick attempt, right? He struggles with it. He's successful for 2 weeks and then he's back on it, right? And then it's the bouncing ball, and those adverts start being the little moments, and it isn't actually until all of his other mates have quitted around him or someone dies next to him that he gets his act together and really focuses down, and even then he might not be successful. So it isn't one intervention that's making a difference in that life course there. It's the gradual accrual of intervention after intervention after intervention. We need to not set ourselves up to fail in health promotion and public health by thinking that a single campaign, a single TV advert is going to lead to changes in lifestyle behaviors that are really deeply embedded in habits. One of the best examples I came across this, I was evaluating a sex worker outreach program in Nottingham, which was run by This was an intervention set up in the 80s around AIDS, HIV, and it was run by sex workers themselves. And I was evaluating it, and I was talking to a lot of street sex workers they worked with. And one of the famous kind of stories that go around at that time was going, so Bruce, it took 1,000 things to put me on the street doing what I do. It's going to take 1,000 things to get me back off the street. It's not going to happen overnight. And most of the time, by the time someone's a street sex worker, really, their life circumstances are pretty badly set up. It's going to be a long headwind to get them out of that set of lifestyles. And that kind of story just is one illustration, I guess, of how deeply embedded those behaviors can become. In relation to obesity, a couple of things you might find useful to peruse if you're not, it's a likely one that can come up at exams, and it's a really interesting, fascinating, big, tough topic. A lot of people draw the first analogy kind of saying, can't we just do a tobacco thing on obesity? And that's pretty hard, and we'll kind of get into that in a moment. But for your information, currently in Australia, we're looking at about 1 in 4, 1 in 3 actually obese, 2 in 3 obese and overweight. So actually people in the normal body weight are actually outnumbered in the population. Now what that means from a normalization perspective is extremely important. Because when we look at ourselves now, we think it's normal. We're not looking at those bodies we were back in the time when, actually, you look at those pictures of kids from the 1950s and 60s, you think they were all malnourished. No, they weren't malnourished. They were actually normal body weight. You know, our perceptions of what counts as normal body weight is really shifted because prevalence is so high now. So there's a series in the Lancet focusing on obesity and obesity prevention. That's well worth having a look at. It goes from everything from the kind of clinical endpoint stuff around bariatric surgery right the way through into kind of progressive public policy and what could occur there. So that's definitely worth looking at. And the UK Foresight report is frequently rolled out as probably one of the most comprehensive ways of looking at the future of obesity and what the drivers of obesity. Now, this is famously called the spaghetti and meatballs diagram, and what it shows is the causal pathways between all of the different factors that influence ultimately outcomes around weight and obesity particularly. And it is truly terrifying to look at in its complexity. A simplified version of it, however, is slightly less terrifying. Sorry, my laptop's not working there. Oh, where's my slide gone? There, that's the simplified version of it. Basically, it looks at a few different domains. One of those being biology, of course. You know, our genes play a part. If we look at it in the physical activity component, there's a physical activity bit which is open to the individual, but there's also the activity environment in which that person is living. If you look at individual psychology, for example, around some of these things such as mindless eating, when you sit on the couch munching away on salty things, and the reason why you munch away on the salty things is because it goes straight to our limbic system, and our taste buds go, "This is great," and we just kind of go with the flow. You know, we just keep going. Our bodies are set up to, obviously, salt, sugar, and fat were rare in our evolutionary past, which is why we're set up to go for them. Unfortunately, now they're incredibly common, and that's the problem, in essence, is that we have Stone Age biology in a modern environment where we have more than enough calories, salt, and fat going around. And that individual psychology is manipulated at a societal level. You know, that's what advertising now. And businesses wouldn't be spending billions of dollars that they do spend marketing junk foods, high energy, if it didn't work. It works, right? And so those societal levels really impact. And then finally, in terms of food consumption, particularly in the food environment. So you can drill that complexity of the obesity foresight map down a little bit to make it simpler. Even easier than that is the Nourishing framework. This is the published framework which focuses on 3 different levels. Firstly, it focuses on the food environment. Next, it focuses on the food system. And then, excuse me, my slides are going funny again. And finally, it focuses on behavior change communication. Sorry, that should read behavior change communication. So to go through that in a little bit of detail, in terms of the food environment, what we mean there is the environment in which people make food choices. And evidence would show interventions are very effective in this area. For example, front-of-pack labeling, that's what FOPL is referring to there. There's an intervention occurring in Australia at the moment where there's an industry public health mediated star rating system that you'll see on some processed foods now, and industry is gradually adopting that. There is a question as to why we've got that one as opposed to something like a traffic light system. Why is it voluntary as opposed to regulated, et cetera, but nevertheless it's evolving. Or looking at kilojoule labeling at fast food outlets that a number of the bigger chains are already doing, and it does vary quite a lot within jurisdictions. So that's about providing cues at an environmental level that try and encourage healthier behaviours. When we talk about food system, something you'll be familiar with from health protection is the concept of from paddock to plate. And it's exactly the same in the food environment. So you're thinking about food system, thinking about everything from primary production right the way through to what appears on your plate. And you can think about a variety of different interventions in that space. For example, taxes and subsidies. Many people argue that actually salt subsidies in the US have a disproportionate impact on global health outcomes. Because actually those subsidies lead to, in essence, very, very cheap and widely available sugar, which is then price isn't a bar to how it could be used in processing. Or indeed product formulation, probably one of the single most effective ways of shaping health promotion outcomes in a healthy eating space, particularly in salt, for example, is by changing salt product formulation. That's in essence taking salt, sugar, and fat that's been added to processed foods out. By the way, if you're looking at the shelves, a little thought experiment for you, something to try out at home one time. If it says low fat, it usually means high sugar. If it says low sugar, it usually means high fat. Check it out on the side of the packet. You'll have a lot of fun with that. If you want to look as well, there's a great app. It's called Food Switch. Try it out, download it, and you can barcode scan foodstuffs, and it will give you not just the nutritional profile of that product, but how it compares to other like products in that food category. And you can have a lot of fun playing around with that app and seeing how that might impact on your own food choices and the food that you eat in your home. Then, of course, the last one, of course, is behavior change communication around, some of the core things we know reduce obesity, breastfeeding, cookery classes, those kind of things. And there's a lot of literature available on all of those issues. So if in doubt in the obesity space, the key messages, I guess, are it's energy expenditure balanced next to energy intake. So physical activity, of course, is a key component, but it's not the key component. Most of your energy expenditure is determined by your basal metabolic rate. Physical activity is really a bit of an add-on. Ultimately, the obesity epidemic is being driven by excess calorie intake, particularly of discretionary, highly processed foods that are high in energy but low in nutritional value. Therefore, we focus on particularly on healthy food environments, and the Nourishing framework is probably the easiest to remember, focusing on the food environment, the food system, and behavior change communication. Then the final one.
I just have a question from Kate, from Kat.
Yep.
It says, what about the concept of food dessert?
Food deserts. Yeah. Look, it's food deserts is it's an interesting one. Food deserts. I mean, certainly in the Australian concept, that definitely applies in some very remote communities. If you go to some of the remote communities in Western Australia, in Central Australia, Northern Territory, it literally can be the case that it's extremely hard to get a hold of any kind of fruit and vegetables whatsoever, let alone anything which is particularly palatable or well preserved relative to the huge amounts of Coke and other highly processed foods that are available. It is one that it's a useful concept and it can be mapped out, but in an Australian concept, it's pretty rare for people not to be able to, in principle, at least be within a stone's throw or a few Ks of a supermarket that does provide fruit and veg. The problem is it's providing it at a price which isn't necessarily the same or as accessible as a lot of the highly processed foods. So I think food deserts, it's a nice concept, but not one that I would heavily rely on. Related to that as well is the concept of food security, and this is the idea, of course, that if you don't have enough money to regularly buy for a healthy diet, and that's again certainly applies in the Australian context. Up to around 1 in 10 households will experience some degree of food insecurity. It is an issue for sure, and particularly for the acutely deprived. But it's in terms of its contribution to population level obesity, probably less of a driver than oversupply of highly processed, energy-dense, nutrient-poor junk foods. Yeah. Any other questions at this stage around obesity?
No, that's the only one that's come through. Thank you.
No, so we'll go on just to conclude then, if people are thinking about their questions for the next bit as well then. So just to conclude with alcohol, and the one I'm going to focus on here is a framework for using. This isn't a published one, it's just useful to know. It's just useful to know, and you can't really talk about health promotion without talking about marketing, because what we're trying to do is social marketing. Social marketing is applying the principles of conventional marketing, but to a social outcome, in our instance, health. And there's 4 bits, for those of you who are unaware of this, around marketing, and those 4 principles are product, place, price, and promotion. And particularly if you're looking at alcohol, both the problem side of alcohol and also the solution side in terms of harm reduction relies on those 4 principles. So at a broad level, per capita alcohol consumption in Australia runs at about 9 litres per person per year. That's in the top 20 internationally of alcohol per capita. Obviously, that's associated with a range of both acute and chronic disease harms, and we'll come on to kind of a little bit about that, because if you look at the product, it's all about the alcohol. It's not about, and this is one of the biggest industry lines around this, is, oh, but wine's different to beer, or beer is different to whiskey and spirits. from a public health perspective, it's all about the alcohol. It's all about how much alcohol before volume is there in this product, and how are people consuming that alcohol. People's tastes for those alcohol do change. So, for example, in the time that Alco Pops tax came in, and that's a product category specific tax, because there was this concern about young people drinking too many Alco Pops, which is basically very sweetened spirit-based beverages that provide a great kind of mechanism to habituate alcohol use among young people whose palates wouldn't immediately swing to some of the less palatable options such as beers and so forth. A specific tax was put on that, and what's that led to? An increase in cider sales. Why? Because in Australia we don't tax by alcohol. That would be a volumetric tax. We tax by the alcohol product. So wine is taxed at a different rate to beer, is taxed at a different rate to Alco Pops, as it taxed at a different rate to spirits, right? So it might make sense from an economic perspective or from a history of taxes perspective. It doesn't make sense from a public health perspective. The most evidence-based way to go would be an alcohol, from a public health perspective, would be a volumetric tax, because you would be focusing on, it doesn't matter where the alcohol is coming from, you're taxing the alcohol, not the product itself. And as long as we retain not having a volumetric tax for alcohol in Australia, will remain with these rather strange anomalies in terms of drinking behaviours, because people obviously, price is one of the critical things that influences drinking behaviour. The traditional gradient, social gradient in risk behaviours, where you see higher levels of risk taking among more deprived groups, actually runs the reverse depending on the indicator that you look at in terms of alcohol. So basically people who've got higher incomes tend to drink more, although interestingly enough, if you look at educational status, people who've got lower educational status drink more. So the picture, that normal gradient, gets much, much more confused when it comes to alcohol, but price, without shadow of a doubt, is one of the principal mechanisms that we've got to influence behaviours there. There is also the concept of the minimum price. That's an idea which is basically there should be a minimum price per unit alcohol. The idea being there that basically what you want to do is get rid of extremely cheap alcohol, sometimes referred to euphemistically in Australia as goon bags, incredibly cheap wine, which basically the evidence shows is drunk disproportionately by people with chronic drinking problems. So you try and knock that out. Well, they're doing it in Scotland, they're thinking about it for the UK, and they'd be talking about it in Australia, but it'd be very, very hard to get up in Australian context. We can then think about not just the product itself, we can think about the place. And this is basically divided into, it's either on-premise drinking or off-premise drinking. We can think about the opening hours. We can think about the densities of liquor licenses. And all of those things are known to obviously clearly impact very significantly. The broad rule of thumb is all of the harms, acute harms, particularly are concentrated on weekend evenings post 12 o'clock at night. That isn't to say there aren't acute harms occurring other times. That's when it all occurs. The big, big ticket harms occur. We can, for your information as well, off-site drinking is more associated with domestic violence, on-site drinking more with acute on-street violence. Price I've referred to before, and then in terms of promotion, we can think about advertising, sponsorship and promotion. It's worth noting that in Australia, it's theoretically illegal to advertise alcohol before 9 o'clock in the evening in order to prevent young kids seeing it. But there is an exemption, which means that for major sporting events, you can show alcohol. So what that means is you can be watching the cricket first thing in the morning with your kid, and there'll be a go-go with alcohol promotion. And basically about 50%, if not more, of all alcohol advertising spending is focused on sport. So that whole concept of you're not exposing kids to that is really pretty poorly controlled here in Australia. So that's just a broad level run through of those big ticket items there. So questions. I'll give everyone online an idea to shoot those questions across, and meanwhile I'll give first shout to Jonathan. Do you want to come around and ask you questions, Jonathan? Just in case people can't hear you.
Oh, yeah. With some of the frameworks and strategies, I think that we're talking here across obesity, alcohol, and tobacco, relative to, I guess, the levels of disadvantage. So we know that higher rates of obesity among disadvantaged, levels of alcohol-related harm are higher in those that are more disadvantaged, and then similarly smoking rates. How do you think, I guess, in terms of which of those elements of those frameworks and strategies that you're talking about that would particularly, target and improve to the health outcomes to reduce those kind of health inequities and inequalities, those kind of low SES settings.
Yeah. So in the question there's around both health inequities and how do we tailor health promotion strategies to reduce the gap. Look, I mean, this is like the holy grail, right? If you can get a strategy that that can improve population health and narrow the gap, that's like incredibly hard to do. The advantage or advantage for a reason, right? It's axiomatic to say the advantage will typically take up a position where they benefit first, right? And that's certainly what we see in most health promotion. Historically, it's been the advantage you take it up first. The first thing to remember in this area is the WHO framework on the social determinants of health, which talks around, and those documents, if you haven't had a look at those, are well worth looking at. It's all up on the WHO website. But the concept here is they talk about differential exposure, differential vulnerability, and differential outcome. So even when you look at, for example, income, where you see lower levels of drinking among poorer people, so there's a lower level of exposure, theoretically, because there's a higher level of vulnerability in those poorer populations, you actually see more harm in disadvantaged groups. So it isn't a linear pathway between exposure and outcome, and disadvantage works in complex ways across that. Vic Health's done a big review of certainly of those 5 big risk factors, smoking, nutrition, alcohol, physical activity, SNAP, often they're referred to as smoking, nutrition, alcohol, physical activity, and then we put mental well-being on the end, so it's like something odd dangling off the end. We've actually commissioned a series of reviews, and they're going to be published in Health Promotion International in the next couple of months. If people want to keep an eye out for those, there's an editorial that's going to kind of summarize those. But broadly speaking, a lot of the whole of population strategies can be effective at narrowing the gap. One of those strategies, for example, but this also kind of shows some of the complexity of this, is tobacco taxes. Now, tobacco taxes are basically, in tobacco, the big 3 are bans, taxes, and social marketing. Right? It isn't that cessation services aren't effective; they are effective. It's just they're not very efficient. Those other 3 strategies are far more efficient. Tobacco taxes, disproportionately, because it's a flat tax, it's a regressive tax, it impacts poor people more than it impacts people on a higher income, and it does drive the gap narrower. Now, while it drives the gap narrower, the relative gap can increase, if that makes sense. While the absolute number of people is coming down, the relative measure of inequality can increase in that time, but certainly the evidence is that it has a disproportionate impact on poorer folk. Smoking bans also can be really effective because basically you're doing it across the entire population. In terms of getting the balance of strategies right, of course, tobacco I'll refer to again, some of those strategies don't reach the hardest to reach groups, or they don't yet. Mental health is a really good example of that. We've got smoking rates that can run upwards in some population groups like prisoners, mental health, Aboriginal, it varies between sort of 50 to 80% smoking rates in those settings. Now, if our whole of population strategies were working, by definition, they would be a lot lower. So quite clearly, there's a lot more complexity happening, and a lot of the energy now in tobacco control as we get down towards 13% and lower as our prevalence rate, which is phenomenal achievement. We've got to start thinking about how do we take what we know works and get them into those communities, but also think about how do we need to develop new strategies to reach some of those groups. And this is where something like e-cigarettes becomes really interesting and really controversial, because internationally the picture is really varied. There are some people who are arguing very strongly that e-cigarettes and harm reduction approaches should be being mainstreamed, particularly in those groups where prevalence remains very high. But then there's, on the other hand, a lot of people who are really concerned about renormalizing smoking, and that e-cigarettes could be a gateway into smoking for young people again. So that's just a lot of complexity in there. So it doesn't answer your question, but in a simple way. But
yeah, sure.
Yeah, I think that useful one, for question answering one, I reckon, is the WHO framework on differential exposure, differential vulnerability, differential outcome.
Yeah,
and you can hang a lot off that. Other questions from folk online?
We do have a few questions. If you just want to hover over your screen for me, Bruce, there's a little speech bubble that you can click on, and there's about 6 questions for you.
Okay, let me have a quick look. Boom, boom.
Where you can see yourself?
Yep.
Yeah, so
Can you see the little speech bubbles at the bottom there?
That one right
this
there.
one here, right, magic.
Yep.
Blank. Okay, magic. Cool. Hey, I'm seeing Laura. Hi, Laura.
Hi. Not sure what I've done.
No worries, generally not. You've got to gaze at my lovely visage. So there's quite a few questions. So there's like 3 here. So we've got about another 10 minutes, so we should be right. So the first one here is from Mithilesh. Is it Mithilesh? I think. So during the time in the past or even the future, do you think there'll be a role in the ban of smoking, where the majority of people want a smoke-free society? Look, I mean, this is one of the big, it's a question that kind of continually kind of comes up, and it's a really interesting question. I think, there are some things about tobacco as a commodity which makes it really quite unique in terms of its harms, right? The absolute harms of tobacco are huge, and if you're a smoker, the chances are, there's a 50% likelihood you're going to die of smoking-related diseases. That does mean, however, you can be a lifetime smoker and there's a 50% chance you will not die of smoking-related diseases, but that is a hell of a hit rate. So that's really the principal argument for why you would go with an all-out ban. However, all of the other experience in alcohol and other drugs is that overall, a criminal justice approach to the control of drugs can be counterproductive. And I think most notably that's around illicit drugs such as cannabis, cocaine, those kind of things, where a lot of people in Latin America, including a lot of prominent politicians, are arguing for a public health approach which prioritizes harm reduction as opposed to an outright ban. Whether or not an outright ban would work in tobacco or not would remain to be seen. There is a special edition of Tobacco Control that, if you want to look it up, there was a special edition about 2-3 years ago now that focused on so-called endgame scenarios for tobacco control, including concepts like bans, ideas like licensing cigarette smokers, and lots of ideas in between. There are concepts of harm reduction approaches, all kinds of different things. For your information, harm reduction-wise, one of the most interesting ones is snus, which is oral tobacco. So rather than obviously the cardiovascular harms come from orally smoked tobacco getting into your lungs, giving you lung cancer and clogging up all your various systems. Snus, because you put it under your lip and it kind of slowly dissolves in, you end up with very high levels of oral and esophageal cancers, but lower rates of cardiorespiratory issues. And the uptake of snus in Sweden and in the Scandinavian countries over the last 15 or 20 years has clearly driven quite a major reduction in smoking-related harms, because it's basically changed the way in which you can be addicted to nicotine. And it's separating out nicotine addiction from tobacco that is where the conversation around e-cigarettes gets really interesting and very controversial. So I think for some people an all-out ban would be a solution. For others, I think they'd be saying it hasn't worked for other drugs, why is it going to suddenly work for tobacco? But what does that end game look like for Australia? I guess we're going to be figuring out, hopefully, all things being well, in the next 10 or 20 years. You never know, we might be getting down to 5% prevalence or something. But even if we get down to 5%, even just in the state of Victoria, that would still be several 100,000 smokers. And Jonathan and I have chatted many a time over what that would mean and whether or not we should take our foot off the gas when you know that there's going to be 50,000 people, in the next 10 years dying of something. So that's that one. There's the next one. Right, so this is one from Sally and Emma. For those working in health promotion, do you have any suggestions for the evaluation of health promotion activities, given what you say about not setting ourselves up to fail, but also not wanting to invest time and energy in ineffective activities? One of the things that we particularly prioritize here at Vic Health is the development of robust program logics. So those are based on, obviously you look at your outcome of interest, then you think about the next steps down the logic chain from that. What are the things that you need to do to get that outcome of interest? And then you frame your evaluation questions off that. And you can separate out, of course, your process indicators from your impact indicators from your outcome indicators. And I completely agree with you. I think the problem with health promotion particularly is that because the vision can be so compelling, we can kind of set ourselves up to fail if we don't look to some of those intermediary advances. I think obesity is particularly important here. A couple of different approaches that people are adopting in the minute. I think they're quite complementary. One is a systems-based approach. So that's really looking at that foresight type of a model where you look at a bunch of interweaving things and you try and operate right the way across a system, across demand, supply, a variety of different things, maybe at a local level, to try and bring about system change. And then there's other approaches where you look at a particular commodity, for example, which is an issue. I mean, the problem with diet is that there's no such thing as an unhealthy food per se. There's hazardous foods, and they should be controlled. You know, if they've got an infectious agent in it, it's a hazard, right? But for most food stuffs, if you're starving to death at the top of the mountain, a Mars bar is a very health-giving thing, right? However, in the Australian context, sugar-sweetened beverages have really emerged as a critical food category that a lot of people are pushing into. Things like Rethink Sugary Drinks, Vig Health H3O campaign, and also Live Lighter. All of those campaigns prioritize in different ways action on sugar-sweetened beverages. And that's because they've got a lot of energy in them and nothing else for nutrition. And really, we don't need that energy for the vast majority of diets in Australia. So you can kind of do that, and then hopefully that'll provide the groundwork for stronger public health action, maybe, for example, taxes on sugar-sweetened beverages in the longer term. So having those robust program logics and being realistic about process, impact, and outcome evaluation is really important. And certainly if we look at the examples of tobacco and TAC, and they're probably the two biggest ones of traffic accident reductions, they're long-running. They take 30, 40 years operating in that Whitehead and Dahlgren type of multiple levels of intervention to retain any degree of efficacy. The next question is from Trent. There's been lots of discussion about the relationship between lockouts and alcohol-related harm. And the critics point out that assault rates in, say, Sydney are at historical lows. Are there studies directly correlating the bans with reductions in these acute harms? Look, there's probably more so than Sydney, because Sydney is a bit more recent, although as I understand it, there is some pretty good data coming out from Sydney, which is independent data, which does show a very rapid decline in alcohol-related harms, acute harms, in the Sydney CBD area. Probably the better example is Newcastle, because Newcastle has had a variety of different controls in place, and most importantly, they've not only been effective, they've also not significantly adversely affected the local licensee economy. While there's been a couple of licensees that have closed down, there's plenty of businesses that are still doing plenty of business while the harms have been reduced. So certainly the Newcastle example is probably a really good example to look at and one to be familiar with for your exams, I'd suggest. And if you just do a quick Google search on that, you should find a lot of the evidence on those debates. Another question, I'm going to do a different question. Ms. Alesh, we might come back to yours. Bhakti is asking, in the intervention ladder, changing the default is an option. What do you think about changing the default about NRT, nicotine replacement therapy? That is, if all smokers are offered NRT regardless of their intention to quit. Look, the evidence is pretty clear. Opt-out systems are far more effective than opt-in systems. But broadly speaking, we do cessation services pretty poorly in Australia, particularly if you compare it to the UK. It's like real gold standard service over there. But the Simon Chapmans of this would argue that most quitters quit unaided, and actually things like NRT, while efficacious and do make a difference at an individual level, that really it's about taxation, social marketing and bans that will drive up the largest number of quitters. Certainly access to NRT is a major issue in Australia, and there is a major opportunity in terms of improving particularly access for poorer groups, given the fact it's an evidence-based intervention. Why wouldn't we be providing it while we're pushing on lots of things like blood pressure meds and doing very little in terms of salt reduction, to draw an analogy. A question here from Cat T saying, good GPs should use the 5 A's framework of motivational interviewing. Yet, so commenting on the same question. Yeah, cool. What about minimum floor price on calories? That's a great observation. Yeah, I think we're a little way off that. Yeah, it's an interesting thought experiment. Look, the reality is, the ammunition that we've got as a public health community is as nothing to the to industry lobbying in this area. So we're a very, very long way from anything around calories. We can't even do product reformulation strongly here. I'm going to wind up in a couple of minutes. So the last question here from Mithalesh is, how does health promotion differ between Australia and, say, developing countries like India or Africa? Look, it does vary hugely. One of the biggest unintended consequences of success in tobacco control in Australia and in well-developed countries is a major push by tobacco industry into low and middle income countries. What we know, many aspects of what we know works in health promotion in high-income countries is potentially translatable to low and middle income countries, but there are lots of additional impediments within that. If you don't have strong trust between communities and government, if government is poorly effective, if at all, clearly it can be very difficult to bring about some of the changes. And anyone who's ever been to India and thought about road trauma there and some of the inroads that we know of what works potentially in road traffic stuff will be able to reflect on the difficulties in implementation. So I think the theoretical frameworks probably are as transposable. It's really about the contexts in which people are operating. And we need to be realistic about some of the unintended adverse impacts that Australia and some of our successes here can have overseas. Certainly tobacco control, I think, is a major area, and it's great and very heartening to see, led in some part, and some significant part by Australia supporting that. So Nathan Grills, who's a ex-trainee in recent times, really pushing on in India around tobacco control and strengthening that. And things like plain packaging, there's no reason why it couldn't be rolled out in those different environments and have, if not quite the same magnitude of effect, at least a significant effect while being extremely cheap and cost-effective. Interestingly, from a Vic Health perspective, Vic Health was established as a hypothecated tobacco tax in Victoria. We're not funded anymore under that. We're used to. Internationally, there's 14 or 15 examples of where that has flown. So there are things which can be directly transposed, I think, from an Australian context. So that's all the questions for today. Thank you so much for your time. I look forward to meeting some of you in person at some point. We'd be nice to have seen some faces at the end of it. But thank you so much for your time. I hope it's been useful for you. And good luck in your training and exams. Fighting the good fight. Look forward to hearing about your successes in the future. Cheers.